Hi, I'm Dr. Jedrzejewski, and I'm here to talk to you about top surgery. So our initial consult will be either over the phone, through video, or in person. We will talk about what to expect in terms of your surgery, but also what to plan for in terms of before the operation, how we can best optimize your health, and afterwards, how to recover from surgery. So the first thing that we'll do when we meet is review your medical history thoroughly. I want you to be as transparent as possible as you can regarding your medical and social history. Everyone has a unique situation, and we want to address your concerns as you have them and work with you to move forward with surgery in the safest way possible. My number one priority is to ensure your candidacy for safe surgery and to optimize your surgical outcome. The things that we want to minimize would be wound healing issues, bleeding, adverse reactions to anesthesia, and other complications. So first, we'll review your medications to look for anything that might put you at risk of bleeding. So non-steroidal anti-inflammatory drugs or NSAIDs, such as ibuprofen, aspirin, or naproxen, may put you at higher risk of bleeding during surgery. So we may ask you to stop these medications about a week before surgery. If you take Tylenol every day, that is totally fine to keep taking. It doesn't affect your bleeding risk. In terms of smoking or nicotine use in any form, such as vaping, it's important to avoid nicotine 6 weeks prior to surgery and 6 weeks following surgery. The reason for this is nicotine causes constriction of tiny blood vessels that we rely on to help you heal from your incisions and your surgery in general. In terms of weight, I do not have a BMI cutoff for top surgery. It's just important to know that with a higher BMI, you have a higher chance of needing a revision after your primary procedure. You could have increased risk of problems with anesthesia. And if you have any comorbidities like heart or lung problems, then these need to be resolved or at the very least optimized by your primary care physician prior to surgery. If you are at a stable weight, 3 to 6 months prior to your surgery, that will yield your best aesthetic outcome. If you have type 1 or 2 diabetes, then we'll ask for a recent A1C blood level. We want to minimize your risk of wound healing and infection, and these complications increase with high blood sugar levels. If you have any autoimmune problems and you take medications, including steroids, we may ask you to stop taking these medications around the time of surgery. In terms of steroids, they're known to affect wound healing in an adverse way. So that would be a medication we'd want to know that you're on. If you have HIV, we'll want to make sure that your viral load is low or undetectable around the time of surgery. So we'll just want to make sure that you're appropriately suppressed. In terms of any personal or family history of blood clots or adverse reactions to anesthesia, this would be important for us to know so that we can keep you safe during surgery. If you have any history of breast cancer, either personal or familial, that would be important for us to know. And if you fall within the range based on current protocols, we may ask you to get a mammogram prior to your operation. Or if you have already had one in the past year and it was negative for any findings, that we accept that as well. I want to know if you have any allergies, either to any drugs or foods or any other medications. I'd want to know if you've had any prior surgeries and how you did during the surgeries, if you recovered well, that sort of thing. Next, we'll talk about social support. So surgery is a physiological stress on both the mind and the body. It's not uncommon to have feelings of negativity or depression or anxiety post-operatively. That can be completely normal. Studies have actually shown that the strength of one's social support network can significantly enhance recovery after surgery. So everyone's social support may look different. For some people, it's family or chosen family or friends or a mental health provider, but it's important to have a plan in place for who's going to support you as you recover from surgery. So before moving on to the physical exam, I want to know what your goals are. For example, some patients might have the goal of having as close to a cis male appearing chest as possible, while others might prioritize nipple sensation over contour. Some patients may find some scar patterns acceptable for their gender expression, while others may not. It's completely up to you. Increasingly, I have patients who choose to opt out from nipples, either because they don't want them at all or because they would like them to be tattooed later on, once they've recovered from surgery. It may be the case that you come to the consult with an idea of what surgical approach you would like, but that may change in terms of based on our discussion of your goals, native anatomy, and your expectations for surgery. So the vast majority of patients who undergo top surgery opt for a double incision mastectomy with free nipple grafts. This involves an incision at or near the inframammary fold, which is underneath the breast fold, and another incision that happens above the level of the nipple areolar complex, or the pigmented area around your nipple. After removal of the breast tissue, the chest is closed, resulting in a flat incision that may curve upward as it approaches the underarms. And that will help mimic the lower border of your pectoralis major muscle. Typically, the nipple areolar complex, or NAC, is made smaller, flatter, and placed more laterally on the chest wall in the form of a skin graft. This approach lends itself to optimization of contour for most body types. However, native nipple sensation is not preserved in this approach. So many patients report the return of sensation several months following surgery, which most likely results from ingrowth of the surrounding nerves on your chest around the nipple graft. So as with any skin graft, there is a risk of hypo or hyperpigmentation, which means lightening or darkening of the tissue, and partial or complete loss of the nipple graft. This is rare, but it's important to know that this is a risk of surgery. So in the double incision mastectomy with free nipple graft, I only use drains on patients who have increased risk of fluid collections due to more tissue surface area with a higher BMI. I don't set a particular BMI for use of drains because it really depends on your body composition and how wide the breast tissue area is. So we can talk about that more at the time of our consult, if you have questions about that. I've just drawn a little drawing here so that you can see what those scars will look like, from a pendulous breast to a flat, straight scar with nipples placed more laterally. So hopefully that helps. So there's a small percentage of patients, about 3%, with minimal breast tissue to start, who may be appropriate candidates for a keyhole or peri-areolar approach. This approach involves an incision around the NAC, or the pigmented part of the nipple areolar complex. And it's an incision that's made full thickness through the lower part. And through that incision is where breast tissue is released from the chest wall and the overlying skin and subcutaneous tissue, and then the breast tissue is removed through that hole. The incision is very well hidden when it's fully healed on most people. And while this approach theoretically optimizes nipple sensation by leaving it partially attached to the native innervation, or the nerves that it currently is attached to on the chest wall, the reality is that nipple sensation after top surgery can be unpredictable. Patients have reported more sensitivity or less sensitivity or the same sensitivity compared to pre-op. And this approach, what this approach does not allow for is any removal of excess skin you might have or repositioning of the NAC, which limits its utility to only candidates with ideal anatomy and good skin elasticity. So this approach is much more likely to result in revision surgeries, especially in patients who are borderline candidates for it in the first place. And this could include excision of excess tissue or fat grafting to any defects. And drains are always used in this approach because there is a higher risk of bleeding and fluid collections with this approach. So some patients who don't want to be completely flat may opt for what is referred to as an inverted T or anchor or wise pattern approach. This is the same technique that is used for breast reductions in cis females and results in a circular scar around the NAC that extends vertically to the level of the inframammary fold and then horizontally along the inframammary fold. Here is an example of what that scar will look like if you start with breasts that are pendulous. I've tried to outline here in red where the scars will be visible, because usually the scar at the IMF, if you have breast tissue that's still existing after the surgery, it kind of hides in that fold. So that would be how that scar pattern looks. Buttonhole is almost the same technique, but without the use of the vertical incision. So that's just something to keep in mind. For both inverted T and buttonhole approaches, the tissue must be left attached to the NAC in order for it to survive. So you can't achieve the same level of flatness that other approaches can give you. Drains may or may not be used in this approach, and that's something we will talk about during your physical exam. So the risks of top surgery are similar to any surgery, including pain, infection, scar. In terms of scars, you'll have a scar wherever we make an incision, and that creates an opportunity for scars to either heal well, or some scars have hypertrophic scarring, which means that they are more raised and noticeable and lumpy and bumpy, or keloid scars, which if you're prone to, what can happen is the scar can extend past the area where we've made an incision and actually grow past it. Those have to do more with what your history of scarring is as a patient, and kind of less to do with the surgery, but it's important to know if you've had these problems with scars in the past, to let us know, because then we can watch for it more closely as you're healing, so we can intervene sooner. There's always a risk of asymmetry. No two halves of anyone's chest are exactly the same. Your rib cage is different on either side. The amount of tissue that you have overlying is different on either side. So we will make you as symmetric as possible, but you won't look like a mirror image of yourself, if that makes sense. That's just something important to know. Sometimes there can be contour deformities, so you might notice that there is an area which feels more raised or feels more indented. That's a risk of surgery. It's something that we can revise in a future procedure, but it's important to know that that is a risk of surgery. Dog ears. So anytime you take a section of tissue out from the body, you have the potential for bunching to occur at the edge of your incisions. This usually happens in the lateral chest wall, and can be very common because we can only extend the incision as much as we can reach your body, because eventually your chest wall meets the bed, and so we can't operate past that point. But definitely later on, there are opportunities to revise. If there's too much bunching, we can revise those dog ears in the future. So there is a risk of hyper or hypopigmentation, as we talked about earlier. And that usually happens at the nipple grafts. So that can be hard to predict. But if you have discoloration of the nipple grafts, then that there's always an opportunity where you can have that kind of camouflaged with tattoo later on once you're fully healed. There's a risk of dehiscence, which means the incision line opens. That happens when there is too much tension on the closure. That can happen for a variety of reasons, but it's a risk of surgery. There can be delayed wound healing, which if you're young and healthy, it usually doesn't happen. But some patients who have comorbidities like diabetes or autoimmune issues may have delayed wound healing. And that's okay. We can get through that and you will eventually heal, but it may result in widened scars or thicker scars, or which can also be revised later on. There's a risk of partial or complete loss of the nipple, which is less than 1%, but it is a risk of surgery that you need to know about. You can have numbness or hypersensitivity following surgery. Usually these resolve over several months, but sometimes they don't. And so that's just something to also keep in mind. Anytime you do surgery on the chest wall, there's a risk of bleeding, and that risk is about 5% chance that the bleeding would require a return trip to the operating room. If this happens, it will usually happen within 48 to 72 hours of your initial procedure. And that's why we ask that you stay in the Bay Area for at least a week after your surgery, so that in case you're one of the 5% that this happens to, that we can take care of you in an appropriate time period. So there's also a risk of having collections of blood that you don't have to go back to the OR for. We just call these hematomas, and usually they'll resolve on their own. Seroma is another type of fluid collection, and that is a fluid that collects in your body anytime you make a space that wasn't there before. So in this case, we lift up tissue from your chest wall and put it back down. And so there is a risk of fluid forming. Usually it goes away on its own. There's always a risk of damage to surrounding structures and need for additional procedures. There's risks of anesthesia, which the anesthesia provider will talk to you more at length, but they include blood clots to the legs and lungs and even death. There's also a risk of regret for having surgery for various reasons. The current literature states that the rate of regret for gender-affirming surgeries is less than 1%, which taken in context is quite low. For example, the risk of regret for elective knee surgery is 10%. So, but it's important to know that that is a risk of surgery. So in terms of the weeks leading up to surgery, about 1 to 2 weeks prior to surgery, we'll have our pre-operative visit, either over the phone or in person. We'll review the surgical plan and you'll receive your prescriptions for your pre and post-operative medications for pain and nausea. On the day of surgery, we'll meet about 2 hours prior to surgery. You'll arrive at either our surgery center or the hospital where we will do your procedure. We'll get your permission to proceed with the procedure that we've agreed on. And I'll do some markings on your chest while you're standing up prior to being escorted into the OR. So the surgery will last 2 to 3 hours. You'll wake up with a chest binder on, and that is important to help reduce pain and swelling and collection of fluid. We inject a long-lasting numbing medication during the surgery, and that will last you about 12 hours from the time we inject that medication. We'll give you a small narcotic prescription in addition to scheduled Tylenol and ibuprofen, as long as you don't have any contraindications to these medications. You'll spend 1 to 2 hours in the recovery area to make sure you've cleared all the anesthesia and that your pain is under control. If you don't live locally, we ask that you stay in the area for at least a week following surgery. So bruising is normal, and there may be small fluid collections that form after surgery, but as long as these are not rapidly getting bigger, it's okay to let them resolve on their own. It's important to maintain your nutrition in the weeks prior to surgery and also during recovery. And it's important to minimize constipation with stool softeners, especially while you're on a narcotic pain medication. If you underwent nipple grafts, you'll need to avoid showering your chest until after your post-operative appointment, which is about a week after surgery. At that time, we'll remove your dressings and examine how your nipples have healed. If you've had a procedure where you needed drains, the drains will come out once the output is less than 30 cc's per day for 2 consecutive days. Um, After that initial post-operative appointment, it's okay to let warm soapy water run over your nipples, but avoid scrubbing the area directly. It's important to shower daily and to apply antibiotic ointment to the nipples for 2 weeks, and then you can switch to Aquaphor or some kind of lotion. You'll have steri strips, which are small white band-aids across your incisions, and just allow those to fall off on their own, which will happen within about 2 weeks. You may start silicone scar treatment once your incisions are fully healed, at the very earliest 3 weeks post-op, and you can buy these online. Keep in mind that your scars will look red and raised for at least 3 months, and then they'll begin to slowly soften, flatten, and lighten over the course of a year. If you begin to develop thick, ropey scars, we can intervene early with steroid injections to help mitigate this. In terms of activity restrictions following top surgery, we'll need you to maintain your binder for at least a week after surgery, sometimes longer if you have significant swelling. It's okay to take this off and adjust the tightness so that it's not inhibiting your deep breathing after surgery. Um, After 2 weeks, you can typically return to a desk type job. And if you have a more physical job, it's important to wait until 6 weeks until you return to your full duties. If you have the ability to return to light duty, that would be really important. And we can always provide a note for your workplace rather. Avoid lifting your shoulders more than 90 degrees for at least the first month after surgery. No heavy lifting more than 10 pounds or walking animals on a leash for 6 weeks after surgery. No submersion into water like a bathtub or jacuzzi until 6 weeks after surgery. And if you've used nicotine prior to 6 weeks before surgery, you may not resume until 6 weeks after surgery. But it's my hope that you can use this opportunity to avoid restarting and improve your overall health. So your scars will take 12 months to fully mature, and it's important to use sunscreen on them anytime they're exposed to light. It is important to note that top surgery is not a cancer operation that removes all breast tissue. It removes the vast majority of breast tissue. This means that you should continue to adhere to routine breast cancer surveillance per current recommendations. In terms of follow-up, after the initial post-operative appointment, which is about a week after surgery, I will see you at 6 to 8 weeks post-op and then at 3 months post-op to make sure that your healing is on the right trajectory. We would love to see you again at 1 year post-op, either in person or virtual, to assess your final result. So at the time of the consult, I will answer any questions you might have. If you have questions that arise after the consult, you can always contact our office and we'll be happy to provide you with more information. We also encourage you to submit ideal photographs of what you envision for your result so that we can make sure we're on the same page at your preoperative appointment. Following the consult, my team will begin the insurance authorization process and will contact you within 2 weeks to discuss timing of surgery. Or if there's any other items that need to be completed prior to surgery scheduling, they'll let you know, like letter of support or mammogram, etc. Thank you so much for taking the time to review this consult for top surgery video, and I very much look forward to meeting you.